Good afternoon to one and all. A very warm welcome to all the attendees. I'm really delighted to welcome each one of you to this first episode of our webinar series, Oncology Insights. We would be focusing on basic concepts in oncology and hematology. Oncology being study of cancer and hematology being study of blood disorders. And the intent of this is to have us empowered on the basic concepts of oncology and hematology, such that we all can make informed decisions, not just healthcare providers, but also caregivers. We'll be focusing on common cancers. We'll be focusing on some basic blood disorders, cancer prevention, cancer detection, and of course, basic treatment options, navigating best through the healthcare system. And I hope this information will be informative and accessible to a broader audience. I'll encourage each one of you to ask questions in the chat box, and we'll be trying to take all those questions in the end. We all know that cancer is the next pandemic. It affects millions of people globally each year. And we have some data. We have some data which is very disheartening. We have about 2 crore people diagnosed each year globally with cancer. We have about 20 lakh people at one point in time in India affected with cancer. The most common cancers globally, when you combine both gender, is lung cancer, breast cancer, prostate cancer, colorectal cancer, and gastric cancer. These are 5 important cancers when we talk about global dynamics. This dynamics is very different in the Asian subcontinent, in the South Asia where we belong. As per Globocan data of 2022, in India, tobacco-related cancers are the most common. Well, in women, we have breast as the leading cause, followed by cervix and ovarian cancer. But unfortunately, in men, one of the most common cancer is lip and oral cavity cancer, which is a tobacco-related cancer. In women as well, the 4th most common cancer is lip and oral cavity cancer. So to discuss what can be done to diagnose the common cancers, what can be done to actually prevent them, and what can be done to bring them at a stage when they are technically stage 0, that is even pre-malignant condition. My participants, my presenters today will be speaking. We all have come together to bring very basic information. If there's anything you want us to elaborate, we'll be happy to elaborate in the end of the session. Every session will be followed by a quiz, which will be 5 questions each. All the questions will have answers in the prior presentation. Very simple questions with answers, and each answer will be about 40 seconds each. We'll try to summarize the 15 questions in the end of the talk and try to give the results most likely at the start of the next webinar. My first presenter is Dr. Venkatesh Babu, who's a surgical oncologist at Fortis Group of Hospitals, and he'll be talking about symptoms and pre-malignant conditions. Over to you, Dr. Venkat.
Hello. Am I audible?
Yes, sir.
Am I audible?
Yes, sir.
Hello. Good afternoon, everyone. As we all know, the number of cancer cases are rising
Sir,
day
are
by
you sharing the slides, sir?
I'll share this. Okay. Good afternoon, everyone. The idea behind today's webinar is that, as we all know, cancer cases are rising day by day, and you being the first healthcare providers, like first exposure to the patients, we want you to empower, and we want you to know that how to diagnose the cancer cases at the earliest and refer them to the proper care as early as possible. So we'll be concentrating on the basics of the oncology, and I'll be talking about symptoms and signs of cancer. Just a second. Share option is not clear. Yes. So, as we all know, any symptoms which are persisting for longer time, that means which are not cured by the initial treatment, that requires a proper attention and proper evaluation. Uh, the as ma'am has mentioned, the most common cancer in India is right now breast carcinoma, and women often suffer with cervical carcinoma, and the most common cancers in males are lung carcinoma of the oral cavity and lip. So we'll be discussing regarding the symptoms of all these malignancies. Uh, so the first, breast carcinoma, as we all know, it is the most common carcinoma. Usually, early cases of the breast carcinoma will not have any symptoms, but in locally advanced and advanced cases of carcinoma can present with some symptoms. Usually, they will present with a lump in the breast or the armpit, which is the most common presentation. And other symptoms includes any ulceration or any change in the skin texture, etc., and nipple discharge. Usually, any unilateral recent retraction of the nipple and any unilateral serous discharge from the nipple, you should get like suspicion of breast carcinoma. Other symptoms include if the cancer has spread out of the breast to other organs like bones, they can have bone pain, and if it is spread to the liver, they can have loss of appetite, jaundice, etc. Okay. And the other most important and the most common cancer among women is thyroid carcinoma. And most of the thyroid carcinomas are usually asymptomatic. And usually sometimes they can present with a swelling in front of the neck. Usually the thyroid swellings moves with deglutition. And sometimes the thyroid carcinomas have propensity, like thyroid carcinomas can be differentiated thyroid carcinomas, medullary CA thyroid, and the anaplastic carcinoma. So the differentiated thyroid cancer can present with a swelling in front of the neck, which most common being solitary nodule thyroid, and the other symptoms being enlarged lymph nodes can be present. And in very advanced cases, there can be involvement of the recurrent laryngeal nerve, which can cause the change in the voice, and in very advanced cases can cause obstruction to the like they can involve esophagus and trachea, which causes difficulty in swallowing and breathing as well. Coming to the other most important, uh, most common malignancies in the female, which includes the gynecological cancers, and most common among this will be cervical carcinoma. Uh, Mostly, the patients with cervical carcinoma present with abnormal vaginal bleeding or postmenopausal bleeding kind of thing. And the other most important cancer being ovarian carcinoma. Usually, early cases of ovarian carcinoma are asymptomatic, and the symptoms pertaining to ovarian carcinoma are very vague. Usually, they will present with distension of the abdomen, loss of appetite, ascites, etc. And uterine cancer, that is endometrial cancer, mostly they will present with the postmenopausal bleeding. And other important gynecological cancers includes vulvar carcinoma and vaginal carcinoma, which can present with the ulcers in the respective regions. Then the other important group of malignancies includes the urological malignancies, and this includes renal cell carcinoma. Renal cell carcinoma usually has a classic triad of pain in the loin, hematuria, and then it can present with a mass or an abdominal lump. Okay, usually, this kind of classic presentation is seen in only 10% of the patients. And other important urological malignancies includes bladder carcinoma, which usually presents with a hematuria. And any hematuria will require further evaluation. Which the minimum basic investigations we do is ultrasound of the abdomen and pelvis, and along with the cystoscopy. And prostate carcinoma is also one of the it is one of the most common carcinomas occurring in the older population, and usually it presents with the symptoms of lower urinary tract symptoms. Usually they will present with the irritative symptoms and then obstructive symptoms, which includes difficulty in urination, frequent urination, especially at night, and blood in the urine sometimes. All that can be the symptoms of prostate carcinoma. And testicular carcinomas, one thing with the testicular carcinoma is that it can occur in the younger population as well. Usually they present with lump or heaviness in the scrotum, And sometimes it can have unusual presentations, like abdominal lump can be present, or they can present with the lump in the supraclavicular lesion region as well. And the penile carcinomas, usually they present with the non-healing ulcers over the skin, that is prepuce, or over the glands, or even sometimes shaft of the penis. Coming to the head and neck carcinomas, the symptoms of head and neck carcinomas usually depend on the subsite from which it is arising. Usually, like if it is arising from the nasal cavity, then there can be epistaxis. And if it is arising from the tongue, there can be a non-healing ulcer over the tongue. And sometimes excessive salivation can be present, and pain can be present. And usually the pharyngeal and hypopharynx and laryngeal lesions presents with changes in the voice and difficulty in swallowing, all that things. Coming to the gastrointestinal malignancies, it's a very broad spectrum actually, and usually I'll just mention about how they present. And usually carcinomas of the esophagus presents with dysphagia, which is progressive. That is, they will start having difficulty of swallowing solids, and then it will progress slowly to, like, to a stage where they will not be able to even swallow saliva. And stomach carcinoma, usually vague symptoms can be present, which includes loss of appetite, loss of weight, and sometimes they can also present with a gastric outlet obstruction, which includes vomiting, etc. And the hepatobiliary system, the most common symptom being jaundice, and the kind of jaundice which we see in malignancy is obstructive jaundice, where they will present with painless progressive jaundice associated with the pruritus. Okay, and other symptoms being loss of appetite, loss of weight, etc. When we talk about loss of weight, it is usually the unintentional weight loss, which is around 10% of body weight in 6 months, or 5% body weight in 30 days. Okay, and lower GI, usually they present with bleeding or anemia. There's a difference between right-sided colonic lesions and left-sided colonic lesions. Usually, right-sided colonic lesions, they present late, and they will present with the anemia. The cecum and the ascending colon have the larger lumen compared to the left side. And usually there will be a polypoidal growth on the right side of the colon, and left side usually there will be circumferential growth. So they present with obstruction more than anemia. And usually rectal lesions presents with anemia. Okay, this is the same thing which I have explained, and this is also the same thing. Right-sided colonic cancers present more common with anemia, and left-sided with the obstruction. And coming to the lung and thoracic malignancies, usually they will present with persistent cough. Any cough which is persisting for more than 3 weeks requires attention, and usually we should be we should be more careful in the smokers, because 90% of the cases of lung malignancies can be attributed to the smoking. So in the other forms in which lung carcinoma can present with includes hemoptysis and chest pain when there is pleural involvement, and they can have shortness of breath when it is an endobronchial growth, or when there is extensive growth is present. And coming to the sarcomas, sarcomas can occur in any part of the body from extremities to the retroperitoneal organs. Usually, the sarcomas presents with a painless lump. Usually, the peripheral sarcomas, any lump which is in the periphery, which is more than the size of a golf ball, usually, like that should raise a suspicion of this thing, sarcoma. And usually, retroperitoneal sarcomas are painless, and they present at a later stage. That's why they present at an extensive stage, where we'll have large tumors involving the entire abdomen. And usually they present with the pressure symptoms because of the pure size of the lesion. And sometimes they can cause obstruction to the urinary tract by causing compression over the ureters. Coming to the bone tumors is also one thing which can present in the younger, like even in the pediatric population as well. They can have a painless or a painful lesion, which is usually present around the long bones. Okay, and X-ray is the basic investigation which will give us a lot of information about the bone cancers. And other topic which I am going to speak today is about the pre-malignant conditions. Pre-malignant conditions are the lesions which will progress to the cancer at some stage, and the percentage varies from different one pre-malignant condition to other pre-malignant condition. And most commonly, we see these pre-malignant lesions in skin, colorectal lesions, and even in the penile carcinoma. I'll be discussing regarding the pre-malignant conditions in detail. Coming to the oral cavity, the most common pre-malignant lesions we see are leukoplakia, erythroplakia, and then lichen planus, oral submucous fibrosis. These are associated with uh, tobacco chewing as well. And usually leukoplakia is any white patch which cannot be categorized into any other lesion. And it has a malignant risk of around 15 to 40%. And erythroplakia, it is a red velvety patch over the mucosal surface, and it has the highest risk of malignancy among all these pre-malignant lesions. And the other things include, the other important things include oral submucosal fibrosis, which is associated with the tobacco, which is also associated with tobacco. And oral submucosal fibrosis ranges from irritation when consuming the spicy food, to the velvety patches, and to the fibrous bands which cause a restriction in opening of mouth. All that things can be present. And these are the some pictures of pre-malignant lesion. First thing, as you can see, it is a white patch over the tongue, which is leukoplakia, and erythroplakia, which has the highest risk of malignancy, and oral submucosal fibrosis, which when severe can cause even difficulty in opening mouth. Coming to the skin, the common pre-malignant conditions associated with skin include actinic keratosis, arsenical keratosis, Bowen's disease, erythroplasia of Poirot, and these are all common um, uh, in case of sun-exposed areas. Like actinic keratosis, usually it is a single solitary lesion with scaly patches, which is present over sun-exposed areas, and the risk of malignancy is around. It's not like we cannot predict the exact risk, but usually they say 1 to 2% risk of conversion to malignance can be present. And regarding erythroplasia Poirot and Bowen's disease, I will be explaining in carcinoma penis. And other important pre-malignant conditions seen with gastrointestinal malignancies includes Barrett's esophagus. Barrett's esophagus is seen among patients who have GERD, gastroesophageal reflux disease, where there is a replacement of the lower esophageal mucosa, and there is intestinal metaplasia. Usually, um, there will be columnar epithelium along with the goblet cells can be seen in the case of Barrett's esophagus. And there is increased risk for adenocarcinoma rather than squamous cell carcinoma of the esophagus in such case. And the colonic polyps, which are the most common pre-malignant lesions in case of lower colorectal malignancies. You might have heard about familial adenomatous polyposis, Peutz-Jeghers syndrome, all that things, all those present with the polyps which progress later to the malignancies. And the risk of malignancy varies with the type of polyp. Usually adenomas have a higher risk, and inflammatory polyps have low risk of conversion to malignancies. And coming to the penile carcinoma, usually penile carcinoma, there are multiple risk factors which includes HPV virus, low lack of hygiene, and even smoking. All that things can be a risk factor for penile carcinoma. And these pre-malignant lesions associated with penile carcinoma can be classified into HPV related and HPV non-related. The HPV related things includes balanitis xerotica obliterans. The HPV related things can be condyloma acuminata, Bowen's disease, and erythroplasia of Poirot, all that. And usually these lesions or the erythroplasia of Poirot and Bowen's disease can be clubbed under carcinoma in situ. And usually they are the superficial lesions with scaly and crusting can be present. And if it appears on the skin, we can call it as Bowen's disease. And if it appears on the mucosal surface, that is over the glans penis or on the mucosal surface of the prepuce, that is called as erythroplasia of Poirot. And other important pre-malignant conditions includes condyloma acuminata, which is also HPV related. And it is usually a warty polypoidal growth, which appears more commonly around the coronal region, as you can see in the picture. And sometimes these coalesce to form a giant condyloma acuminata, also called as Pascal-Levenson tumor. Okay, and other pre-malignant conditions includes non-HPV related includes balanitis xerotica obliterans, which is nothing but a fibrosis with blanching and cicatrization around the preputial skin. All this can lead to the malignancy of the penile region. This is regarding the symptoms and pre-malignant lesions associated with common malignancies. Um, Thank you. And next we'll be proceeding with the first round of quiz, and Dr. Shweta will be taking over.
Uh, Thank you, Dr. Venkatesh Babu, for detailed description about what detailed insights into what signs and symptoms you should look out for early detection of cancers. Hello everyone, and I will not make you wait for long. I'm going to introduce I'm going to read out the instructions for the rules and regulations of the quiz. After each round of presentation, we'll have 5 MCQ questions. All participants have to click on the quiz option, which will be on the right corner of your page. Just click on the button, and questions will be presented on the screen to you. You have to choose the correct questions out of ABCD, and each question will be for 45 seconds. And uh, first preferences will be given mainly for non-oncologists who answer very fast. And in case of any tiebreaker, um, whoever is answering the question fast will be given will be selected as a winner. So I hope everyone has clicked on the quiz option displayed in your page. Question number 1: most common cancer among the Indian population. Option A, lip and oral cancer. Option B, lung cancer. Option C, breast cancer. And option D, colorectal cancer. I repeat, most common cancer among Indian population. Next question, question number 2. Among the following, which is not a carcinogen? Option A, nicotine. Option B, acrolein. Option C, PAH. And option D, benzene. Next question. Third question, what is significant weight loss? Option A, intentional 10% loss in 6 months. Option B, unintentional 10% loss in 6 months. Option C, intentional 20% loss in 6 months. Option D, unintentional 20% loss in 6 months. I repeat, What is significant weight loss? Next question. Question number 4. Which of the following malignant condition have highest risk of malignant conversion? Option A, lichen planus. Option B, oral submucous fibrosis. Option C, erythroplakia. Option D, leukoplakia. I repeat, which of the following pre-malignant conditions have highest risk of malignant conversion? Last question of this round 1. Which genetic syndrome is associated with a high risk of multiple malignancies, including breast, leukemia, brain tumors, and adrenocortical carcinomas? Option A, Lynch syndrome. Option B, Lee-Fraumeni syndrome. C, Cowden syndrome, and D, Peutz-Jeghers syndrome.
So it was an extremely insightful presentation. Actually, we learned a lot of new things about how to uh, understand the symptomatology, how the patients are how they present. And we'll have the next talk by Dr. Sonali Shinde. She'll be talking on early detection and cancer prevention.
Madam, are you sharing the slides or should I?
नहीं आप ओपन कर primary prevention, secondary prevention, and tertiary prevention. Primary prevention being the intervention implement for eliminate the cause. We are trying to prevent the sequencing of this.
Hello, madam, can you hear us?
What is
No problem.
Uh, what is screening? Screening refers to the use of simple tests across a healthy population to identify those individuals who have a disease but do not yet have any symptoms. The goal of a screening is to reduce mortality and or severity of the disease through early detection and treatment. Now here I'll be explaining about the lead time. When the patient presents with a cancer detected symptoms, the perceived survival time will be less. But if through screening, we'll get a lead time, and wherein we help in detecting the cancer before perceived by the patient. So 1 in 3 cancer deaths can be prevented with early detection. So breast cancer, the cancers which can be screened screened and early detection is possible are mostly breast cancers, cervical cancers, lung cancers, oral malignancies, colorectal cancers, and prostate cancers. And coming to breast cancer screening, average risk, like in breast cancer screening, there are 2 risk groups. Average risk group and average risk group and high risk group. Average risk group, individuals in the population between the age of above the age of 20, we usually start screening. And here the screening method will be basically self breast examination and clinical breast examination. And there is self breast examination which the individual can do it monthly at their home only, and which has to be we can use a timeline between 5 to 7 days after the post the periods of the patient. The clinical breast examination will the person has to get a clinical examination, breast examination yearly about the age of 20 years. And mammogram, that is a bilateral mammogram of the breast, is preferred between the age of 40 to 50 years annually, and and above 50 years it has to be done biannually, that is every 2 years once. Ultrasound of breast is preferred in in any individuals who are below the age of 40, and below the age of 40, as in they have a dense breast, and which will give false positive and negative results in mammogram. So, what are the high risk groups? High risk groups are people who are individuals who are having a personal history of breast cancer, or a person who is having a first or second degree family history is there of any cancers in the family. Any genetic mutations are there, like BRCA positive, or the other genes positive. 5-year risk of invasive breast cancer is there in more than or equal to 1.7% in women above the age of 35. These risk factors can be lesser age of menarche and or late menopause, multiple uh, elderly first pregnancy, that is if first pregnancy is above the age of 35. And these are some of the risk factors wherein their 5-year risk of invasive breast cancer will become more than 1.7%. And history of radiation to chest wall between the age of 10 to 35 years. So in all these high risk group individuals, what are the tests recommended? Self-breast examination, definitely, which they have to do it monthly once. Clinical breast examination, the person starts from the age of 20 to 25 years only, and it is usually started 10 years after the person has received any radiation, that radiation to the chest wall, and has to be done every 6 monthly once. Mammogram, bilateral mammogram, has to be started from the age of 40 years and has to be done annually. MRI breast, also we have to start from the age of 25 and it has to be done annually, and it is usually taken up as 10 years post the start of if the patient has received any radiation, it has to be started 10 years post starting of radiation. So this is the way we do a self-breast examination in the individuals, wherein the person will stand in front of in a standing position and in the sleeping position. It can be done, and these are the methods how it has to be done. So next, coming to cervical cancer screening. Cervical cancer screening, herein women between below the age of 21, there is no need of doing any screening modality. But from the age of 21 up to the age of 65, all women should undergo a pap smear, and from the age of which has to be done every 3 years once, and from the age of 30 to 65, the patient, like women, can undergo PAP and HPV core testing every 5 years once. So above the age of 65, there is no need of doing any tests. If no need of doing any tests, there is no need of doing any tests if any patients have there is no need of doing any test if any of the three consecutive pap smears have come negative, or any two consecutive PAP and HPV testing has come negative. So this is the method in where these are the timeline in which cervical cancer screening has to be done. So when a person should do go for a pap smear between the menstrual cycles is it is good to do a pap smear between the age of between the day 9 to day 20 of your menstrual cycle period. So next, I'll be talking about HPV vaccine. HPV vaccine is HPV virus is the most common cause of cervical cancer. It causes about 80 to 90% of cervical cancer is caused by vaccine, HPV virus. So what are the types of viruses which can cause HPV cancer? Is HPV type serotype 16 and 18 causes about more than 75% of cervical cancer and more than 50% of vaginal and vulval cancer. And other high-risk groups of HPV virus serotypes are 31, 33, 45, 52, and 58. So there are certain non-cancer causing serotypes also, like 6 and 11, which causes about 90% of anogenital warts. So HPV vaccination is available in India, which are there are 3 types of vaccines available in India, which will give protection against cervical cancer, vaginal cancer, vulval cancer, anal cancer, and anogenital warts. The 3 types of vaccines which are available are Gardasil 9, Gardasil, and Cervavac. The schedule which is usually followed is from the age of 9 to 15 years. It is for both boys and girls. And the schedule is 0 and 6 months. From above the age of say 50 up to the age of 26, it is 0, 1 to 2 months and 6 months. And less than 45 years up to 0 to 2 months and 6 months once. That is a three dose schedule is followed from the age of 16 to below 45 years. And this reduces the risk of various cancers associated with HPV virus and genital warts. But even after the even after the whole vaccination schedule is over, the individual has to continue to get the screening done regularly. So next, I'll be talking about colorectal cancer. Colorectal cancer screening, it's again divided into average risk individuals and high risk individuals. High risk individuals being patients who are already having any adenoma, polyp, or family history, positive family history is there. And so colorectal cancer screening is done from the age of 45 to 75. And high risk individuals, we usually start from the age of 40 or 10 years before any the family member who is already diagnosed with cancer. So here colonoscopy is done, which is every 10 years once, or a flexible sigmoidoscopy, which has to be done every 5 years once, and an yearly annual testing by fecal immunochemical test, fecal occult blood test, fecal stool test for to checking the occult blood can be done. So next, lung cancer screening. Lung cancer screening is done here the average individuals who are between the age of 50 to 80-year-old and who are having a current history of smoking or have quit smoking in the past 15 years, and along with current smokers who have a history of 20 pack years or greater history of smoking is there. In these individuals, lung cancer screening is being done, and the preferred method for doing a lung cancer screening is usually a low dose CT, which has to be done annually. Next, about oral cancer screening. Oral cancer screening is usually done can be done by the individual themselves by self-examination, in which the individual can check if there is any red patches or erythroplakia present in the oral tissues, any pain in the mouth or referring to the ears, referral pain to the ears, any abnormal lumps or thickening if the tissue is present, difficulty in chewing or swallowing is there. If there is any lump in the neck, any white patches are present in the oral cavity, any ulcers are there which are not healing for about 3 to 4 weeks, or a chronic sore or sore throat or hoarseness is there, then all of these individuals will have to do or any pre-malignant conditions are there, as in Dr. Venkatesh sir told already. So all of these patients will have to undergo any series of tests, and we have to check for if any malignant conditions are there. Next, in prostate cancer screening. Prostate cancer screening, we'll usually do a serum PSA and a digital rectal examination, which has to be done yearly or yearly based on the age of the patient and age of the individual. And it is usually started according to the NCCN guidelines. The screening for prostate cancer is started from the age of 45. And up to the age of 75, or it's considered up to the age wherein life expectancy is considered less than 10 years. And if any high risk individuals are there, or like family history is there of prostate cancer or BRCA positive history is there in the family, then we start the prostate cancer screening from the age of 40 itself. So what are tumor markers? Tumor markers are substances produced by cancer cells or by the body in response to cancer. They are found in blood, urine, or tissue and can be used to detect cancer, determine prognosis, and monitor treatment response and check for recurrences. So the common tumor markers which we use are for colorectal cancers, we use CEA, prostate cancer, PSA, ovarian cancer, CA125, again, liver cancers, AFP, testicular cancers, beta HCG, pancreatic cancers, CA 19.9, and breast cancer, CA 15.3. These cancers can, these tumor markers can help in determining the, help in screening, monitoring of treatment, sometimes diagnosis, like in liver cancers, where in AFP, if more than 200, then there is no requirement of any biopsy, and to check for recurrences regularly. Thank you. So next, we will have a quiz session, session 2 of quiz session. So I'll be handing over to Dr. Shweta.
Thank you, Dr. Sonali, for giving us details about the importance of screening and what screening techniques are available at present to detect cancers. Going on to round 2 quiz, 5 questions will be there. So question number 1, what is the high risk human papilloma virus strain causing cervical cancer? I repeat, what is the high risk human papilloma virus HPV strain causing cervical cancer? Option A, 16 and 18. Option B, 6 and 11. Option C, 30 and 35. Option D, 12 and 19. Question 2. What is the following cervical cancer screening test which is highly efficacious? A, ultrasound abdomen and pelvis. B, colposcopy. C, HPV and PAP co-test. And D, dilatation and curettage. I repeat, which of the following cervical cancer screening tests? A, ultrasound abdomen and pelvis. B, colposcopy. C, HPV PAP co-test. And D, dilatation and curettage. Question 3 of round 2. Which of the following is the recommended screening method for lung cancer in high-risk individuals? A, low-dose CT scan. B, chest X-ray. C, annual sputum cytology. And D, pulmonary function test. Which of the following is the recommended screening method for lung cancer in high-risk individuals? Option A, low-dose CT scan. Option B, chest X-ray. Option C, annual sputum cytology. And option D, pulmonary function test. Question 4. Which screening tool is recommended for the early detection of hepatocellular carcinoma in patients with cirrhosis? I repeat, which screening tool is recommended for the early detection of hepatocellular carcinoma in patients with cirrhosis? A. Chest X-ray. B. MRI of the abdomen. C. Serum AFP levels and ultrasound. And D. Colonoscopy. Moving on to last question of round 2. Which of the following genetic mutations is most commonly associated with hereditary breast and ovarian cancer syndrome? Which of the following genetic mutations is most commonly associated with hereditary breast and ovarian cancer syndrome? Option A, BRCA1. Option B, TP53. Option C, KRAS mutation. And option D, APC. I hope you answered your questions. Now, I would like to invite Dr. Sharat Chandra, consultant surgical oncologist, to give a detailed discussion about lifestyle modification and risk factors associated with cancer.
Everyone, myself Dr. Sarat Chandra, surgical oncologist at Fortis Hospitals, Bangalore. I will be briefly covering the topic that is the risk factors for cancer. This includes the various lifestyle factors also. So if we look at the entire, there's a big list of risk factors which can lead to the development of cancer. We know that cancer is a disease of the cells, the uncontrolled, unwanted multiplication of cells because of abnormality at the genetic level. You can see the number of insults, the entire list. All these things are known to cause defect at the genetic level. Some of the genetic defects induced by these inciting factors are repairable. If the cell is not able to repair these genetic factors, then it can lead on to uncontrolled, unwanted excessive multiplication of cells. Old cells don't die. So this is what leads to cancer. So if we look at the commonest risk factors for cancer, we know it is said during our learning period that the first cause of cancer is tobacco, second cause tobacco, third cause tobacco, like that they used to tell. So tobacco is such an important cause of cancer worldwide. And I will be elaborating on the individual risk factors subsequently in my slides. The other risk factor being alcohol consumption. Certain nutritional factors are implicated in the causation of cancer. Patient having excessive body mass index, we call it obesity. Not only that, lack of physical activity, sedentary lifestyle, and genetic factors are known to play a role in carcinogenesis in about 5% of the cancer patients who present to the OPD. Certain infections like human papillomavirus, hepatitis B virus, and hepatitis C virus are known to cause damage to tissues and in the long run lead to certain cancers. Again, chronic inflammation, we know chronic burn scars over the scar. We have learned in our surgical classes that Marjolin's ulcer. These things can happen. Any chronic irritation, any insult that happens that goes on to the genetic level and is not repairable can lead on to cancer. Similarly, ultraviolet radiation in certain ranges. Not only that, we know carcinogens and chemical exposure like asbestos causing mesothelioma, and benzene exposure in coal tar gas. It can cause leukemia. These things are known. It is not clearly known whether the electromagnetic radiation that cell phones can cause cancer or not. Is still being studied. So coming to the most important causative factor for cancer, that is tobacco consumption. India is known to be the second largest producer and consumer of tobacco in the world, only following China. If we look at the epidemiology of tobacco-related deaths, not in particular cancer, it is understood that around 13.5 million deaths happen in our country every year, which are attributable to tobacco consumption. This is a habituating or addictive thing, the tobacco consumption. And we know there are a lot of n number of tobacco products that are available in the market. Here we should understand that tobacco consumption doesn't necessarily mean that it's a smoked tobacco. 80% of tobacco consumption in our country is in the form of smokeless tobacco, that is gutka, pan, jarda, khaini, etc. So 20% of consumption goes in the form of cigarettes, chuttas, bidis, and all. Now there are various fanciful modifications of the cigarette consumption, like e-cigarettes, cigarettes with filters, all these things. They tried different methods to see if the carcinogenic effect of the tobacco can be overcome, and still the person can consume tobacco. But finally, it was very clear that tobacco consumed in any form is going to be carcinogenic. Not only that, it can harm the lungs, the heart, and various organs of the body. So tobacco consumption in any form is carcinogenic. Even passive smoking, as we know, is carcinogenic. So tobacco cessation, this is the very important thing. And there are various methods which have been approved by the FDA, Food and Drug Association. The main addictive component in tobacco smoke is nicotine. We were told by our teachers that nicotine is not carcinogenic. It is actually the addictive component of tobacco, which leads to dependence or habituation or addictive thing related to the tobacco. The actual carcinogenic agents in the tobacco smoke being polycyclic aromatic hydrocarbons, aromatic amines, nitrosamines, aldehydes, ethylene oxide. These are the actual carcinogenic compounds in tobacco smoke. It is said that more than 2,000 harmful chemicals are there in tobacco smoke. So what are the recommendations with respect to lung cancer screening? As my colleague Dr. Sonali has already covered, I'm not going to tell about that, the US Preventive Services Task Force recommendations. So let us discuss about the effect of smoking and smoking cessation on treatment outcomes. Suppose we are doing a cancer surgery for a patient who is actively smoking. He has a very high risk of perioperative complications. Not only is tobacco a cause of his cancer, but also it actually hampers the post-operative recovery of the patient. See, not only surgical post-operative recovery, but also the chemotherapy tolerance, the radiation tolerance, the side effects of it. It's very difficult to treat a patient who is actively smoking. Similarly, someone might put a question, okay, we have smoked for so many years. Is there any benefit of quitting smoking after smoking it for many years? Yes. However long a patient smokes, if he completely quits smoking, the beneficial effects of that quitting from smoking will definitely help the patient a few weeks following cessation. So there are things called electronic nicotine delivery systems, which have been tried as alternatives to smoking because patients are unable to give up smoking in spite of an intention to do so because of the addictive effect. So these are called electronic nicotine delivery systems. So these are in the form of some liquid will be there. It is heated and then vaporized, and the patient inhales the vapor. So that gives a kind of kick which is similar to the smoking. So these things are used as supplements or for weaning the patients from smoking in the de-addictive process. These, according to the UK data, these things are considered safe, but there is a lot of controversy in the US data. Finally, it is not very clear because about whether these electronic nicotine delivery systems are really effective or not. So there are various terms with respect to tobacco smoking. Never smoking means the the person has never consumed more than 100 cigarettes in his life and is not actively smoking. Former smoker means he has consumed more than 100 cigarettes in his life, but he actually quit smoking more than a year ago. Recent smoker means he has consumed more number of cigarettes, but he has quit only within the last 1 year. And current smoking, as we can understand, is actively smoking cigarettes. So what is the actual way that this tobacco consumption should be curtailed? The government is not going to stop tobacco production because of a lot of taxes involved, lot of revenue involved. The farmer is never going to stop growing tobacco because it's a very lucrative crop, and once you grow tobacco in a soil, you cannot grow any other product in the soil because the toxins remain in the soil. So neither the government is going to stop nor the farmer is going to stop growing. So it is only self-ban out of self-awareness that we should try to quit tobacco. Similarly, alcohol consumption is also addictive. The mechanism of carcinogenesis in alcohol consumption is that the end products of alcohol metabolism is understood to be acetaldehyde in the liver, which is going to hit the cells at the genetic level and cause cancer. Not only that, alcohol consumption also causes various nutrient deficiencies, which can eventually lead to cancer formation. So head and neck cancers, breast cancer, colorectal, liver cancer, stomach, pancreas, all these cancers have been attributed to alcohol consumption along with smoking. So when person consumes both alcohol and tobacco, the combined effect is understood to be not additive but actually multiplicative. So coming to the nutritional factors in cancer, there are very few studies which definitely show some association of cancer with high intake of sugar sweetened beverages, at the same time consuming very low quantities of whole grain in the diet, especially colorectal cancers. Similarly, high alcohol consumption, we see a lot of head and neck cancers, stomach and liver cancers developing in these patients. Surprisingly, endometrial cancer is nowadays linked more often with the consumption of foods having high glycemic load, high sugar content. So very obese ladies, or so they are known to have this risk for endometrial cancer. Ultimately, it boils down to not any particular single nutrient, whether one person consumes that particular food or not. It is not just that single food, but actually the pattern of the diet that the patient or the person follows. How many times he eats in a day, what time of the day he eats, whether it's a healthy food, whether it involves a lot of vegetables and fruits or not, whether any Western diet with processed foods with preservatives, additives. These are the actual things that it is the general food habits of the person which determines the nutritional risk of cancer than consuming or not consuming of a single product. Obesity nowadays, for example, if you take developed countries like United States, because of awareness, they're trying to curtail the amount of tobacco consumption. At the same time, there is another risk factor which is coming up, which is obesity, and soon it is expected to overtake tobacco as the leading risk factor for cancer, especially in the developed countries. 3/4 of the population being unaware that obesity itself can predispose to cancer. How can obesity cause cancer? It's not directly explainable, but we know that obesity is associated with various metabolic changes in the body, like metabolic syndrome, low-grade systemic inflammation that is going on in the tissues, various hormonal changes, especially high insulin levels and resistance, and also the circulating steroid hormones. So all these factors put together are going to create a milieu in the tissues, the microenvironment, which is congenial to the cancer cell proliferation. So that is how obesity is understood to predispose to cancer. If we look at the list of cancers which you can see in the slide, there is various cancers in which there is sufficient evidence that maintaining a normal BMI is supposed to be somewhat protective against these cancers, like esophageal adenocarcinoma, gastric cancer, colorectal, liver, gallbladder, pancreas, breast, uterine, endometrium, ovary. Many of these cancers, it is understood that normal BMI actually kind of protects the patient from these cancers. Similarly, the amount of physical activity, it is more than the physical activity, the regular physical activity that is very important in preventing cancer. There are multiple systematic reviews which have found an association between the amount of physical activity and various cancers like bladder, breast, colon, endometrial cancer, esophageal adenocarcinoma, renal and gastric cancers. So regularity of the physical activity is the important thing, which is understood to lower the risk of multiple cancer types. Sedentary behavior is known to increase cancer risk by 20%, with a lot of people spending a lot of time with the screen time, with the televisions, laptops, mobile phones, eating fast foods. So these are the things which are understood nowadays too. So they say sitting is the new smoking. So lifestyle guidelines which can help us in preventing cancer. All of us we have already discussed. To achieve and maintain normal healthy weight, be physically active, follow healthy eating pattern at all the ages. One should not feel that one is very young and we can deviate. Ultimately we have to live long. So tobacco cessation and avoid and limit alcohol intake. Yes, genetic risk factors, though in a subset of the cancer patients, this is a very important thing because it has a lot of treatment and counseling implications. Here we should understand the difference between pre-malignant condition and pre-malignant disease. Pre-malignant condition means, as my colleague Venkatesh has discussed, leukoplakia, erythroplakia. So these are the pre-malignant conditions. It is there only in that particular patient, it is not in the family. Whereas pre-malignant disease means he has born with some disease, by birth he has attained some disease which predisposes him to cancer. Hereditary cancer syndromes, there are a lot of cancer syndromes which are exclusive cancer syndromes, and there are syndromes in which, like Down syndrome patient being predisposed to leukemia. There are syndromes which are non-cancer, by birth they are non-carcinogenic, but and they end up developing certain cancers like Down syndrome. And there are pure cancer syndromes also. There are various known and unknown genetic mutations which are understood to be the reason for hereditary cancers. As we have studied, the proto-oncogenes and the tumor suppressor genes, these are the two opposing forces at the genetic level, and defect in any of these things, defect in the repair mechanisms of any genetic damage, they can lead to cancer. And the inheritance patterns are there. Tumor suppressor gene defects being more autosomal dominant inheritance, and proto-oncogene defects being autosomal recessive most of the times. It's not necessary that if a patient has a genetic defect, he should definitely, like adenomatous polyposis coli APC gene, it's not necessary that 100% he will develop the cancer. He may have a genetic defect but still not develop cancer in his lifetime. This is what is called gene penetrance. So certain genetic mutations like adenomatous polyposis coli, BRCA gene mutations in breast cancer, these are known to have very high genetic penetrance. In his life, he'll manifest that particular cancer. But this is not the case with all genetic defects. Though the defect is there, if it is a low penetrance, he may not manifest it in his life. Genetic counseling is very important before proceeding with genetic testing, because we should be equipped to handle a positive or a doubtful report. So genetic counselors are there, oncologists, the clinicians are there. So genetic counseling is a very important part. Testing for hereditary cancers, we have various methods to test for the presence of hereditary cancers. Patients come asking us whether they had a father or mother with cancer. They want to know their risk. Then we can do what is called HRR panel or NGS testing. There are various testing modalities nowadays which are very easily available than they were 10 years ago. Similarly, the post-testing interventions are there. Suppose somebody is found to have a genetic defect, then we have certain treatment options, whether they have to put under close surveillance or to do a preventive surgery or to give them any medication to prevent the development of cancer. The guidelines are there in place. So there are also other causes of cancer, like certain infections, as been already discussed, the human papilloma virus associated with carcinoma cervix, the hepatitis B and the hepatitis C viruses, though not directly carcinogenic, they cause chronic inflammation, and any chronic inflammation or chronic irritation of the genes can cause cancer. Similarly, chronic inflammation, I told burn scars, chronic burn scars, one can develop a squamous cell carcinoma, we call it Marjolin's ulcer. So these are known to predispose to cancers. So ultraviolet radiation in certain ranges is understood to cause skin cancer. Carcinogens and chemical exposures like benzenes, aldehydes, the asbestos, are known to be carcinogenic. It is believed that if we take the history of a patient with pleural mesothelioma, 100% we will find out some exposure to asbestos in his life. That is the amount of association of asbestos with pleural mesothelioma. Similarly, the immunodeficiency states. We know the body's immunity tries to get over the cancer at the early stage. Small cancers can be eliminated if the immunity is good. In fact, some of the cancers are known to have spontaneous regression by themselves. Probably these are immune mediated. So immune deficiency states like acquired immunodeficiency syndrome due to the HIV virus, they are known, we know that they are predisposed to certain cancers like cervical cancer, uterine cervical cancer, the anal cancers, and lymphomas. These are very common in chronic HIV infected patients. So this will briefly summarize the risk factors and the lifestyle modifications pertaining to cancer. Thank you very much.
Thank you, Dr. Sharath, for for making a point that preventing certain risk factors, which is always better than crying for a cure later. Going on to the last session of quiz, last round of quiz. Question number 1. Which of the following lifestyle modification has the most significant evidence for reducing the risk of breast cancer recurrence in survivors? I repeat, which of the following lifestyle modifications has the most significant evidence for reducing the risk of breast cancer recurrence in survivors? A. Weight loss through a calorie-restricted diet. B. Regular physical activity, particularly moderate to vigorous intensity. C. Reduction in alcohol consumptions to less than 1 drink per day. And D. Complete cessation of all dietary fats. I request the participants to click on the quiz button which is displayed and answer the quiz. Going on to the second question, which dietary component has been linked to an increased risk of colorectal cancer, particularly in high amounts, and should be limited in cancer prevention strategies? Which dietary component has been linked to an increased risk of colorectal cancer, particularly in high amounts, and should be limited in cancer prevention strategies? Option A, fiber diet. B, red and processed meat. C, omega-3 fatty acids. And D, vitamin D. Question number 3. In terms of body mass index and cancer risk, which of the following cancers has the strongest association with obesity? Option A, pancreatic cancer. B, colorectal cancer. C, endometrial cancer.
Option D is DKA induced mutation. I repeat, which of the following describes the relationship between diabetes mellitus and cancer? Option A, oral hypoglycemic agent induced liver dysfunction, hyperinsulinemia, B, metformin induced pancreatic cancers, or diabetic ketoacidosis induced mutations. Question number 5, last question of this. Last question of this webinar. In the context of obesity and cancer, which of the following is the most likely biological mechanism linking obesity to an increased risk of certain cancers? I repeat, in the context of obesity and cancer, which of the following is the most likely biological mechanism linking obesity to an increased risk of certain cancers? Option A, increased oxidative stress and chronic inflammation. B, decreased immune surveillance. Option C, genetic mutations in the adipose tissue. And option D, altered metabolism of estrogen and insulin-like growth factors.
So I think with this, we come to an end of our session. I sincerely thank all the speakers. There was a slight glitch, and I really ask for forgiveness for that. I really thank all the attendees. We had about 198 attendees today. We have made an Excel sheet of all the people who have participated in the quiz. And the initial part of 14th February webinar, we'll be announcing the winners. The first winner will get 12,000 rupees of cash award. We'll connect with them and try to do an online transfer or get a bank transfer. The second awardee will be given 8,000 rupees of cash prize, again, through either an online transfer, through a UPI or a bank transfer. The next topic on 14th February, starting at 3 p.m., is pediatric hematology and pediatric oncology. I request all the general practitioners, pediatricians, or any subspecialists who are interested to be a part of it. And please ask us questions in the chat box for anything which is related to that topic or even unrelated oncology or hematology questions. We all will be happy to answer. We will also be writing our email in the presentation so that if there is any email question, we can take that too. Thanks so much for joining today. Have a good day.
So, quiz number 1, round 1 answers. What are the most common cancer among the Indian population? To go about this confusing question, the most common cancer among the Indian population in both sexes is a breast cancer, which ranks with a number of cases of 13.6 and prevalence rate of 77.9 per 1 lakh population. Second question, among the following, which is not a carcinogen? Among these, nicotine is not a carcinogen. Nicotine is mainly an additive agent, which leads to the blockade in the receptors and develops, given rise to dependence and withdrawal responses. So, nicotine is mainly an additive agent which causes positive reinforcing aspects. Question 3: what is significant weight loss? The answer is unintentional 10% loss in 6 months, or 5% weight loss in 30 days, or a body mass index of less than 21, change in appetite, smell, or taste, and change in fitting of the cloth. Which of the following pre-malignant conditions have high risk of malignant conversions? Erythroplakia, we can see a red patchy thing which cannot be scrubbed out, and mainly the erythroplakia have a conversion rate of 41.2 into squamous cell carcinomas. Which genetic syndrome is associated with an increased risk of multiple malignancies like breast, leukemia, brain, and adrenocortical? It's Lee-Fraumeni syndromes, which is caused due to a mutation in the TP53 tumor suppressor gene. What is the high-risk human papilloma virus strain causing cervical cancer? It is strain 16 and 18. There are multiple subsets of HPV strains which has been connected to a development of pre-cancerous and cancerous lesions, and out of which 16 and 18 is mainly involved, 83% involved in cervical cancer, which can be prevented by an HPV vaccination schedule to more than 95%. Which of the following cervical cancer screening test is accurate? HPV and COPAP test, which has been recommended by the screening task force. Doing a core test once in 5 years is sufficient up to age of 60. Which of the following is the recommended screening method for cancer, lung cancer in high-risk individuals? It's a low-dose CT scan, which again has been approved by which is incorporated into the screening guidelines of US task force, mainly in high-risk individuals who is smoking for more than 20 years. Which screening tool is recommended for the early detection of hepatocellular carcinoma in patients with cirrhosis? It is serum AFP level, and ultrasound has to be repeated every 6 months once. As you can see, the AFP level and the risk of hepatocellular carcinoma, based on the level, for the fold, the cancer risk increases more than 22-fold. Which of the following genetic mutation is most commonly associated with hereditary breast and ovarian cancer syndrome? It is BRCA1, and it is associated with 35 to 70% of hereditary breast and ovarian cancer syndromes. Which of the following lifestyle modification has the most significant evidence for reducing cancer survivors, recurrence in survivors, intensity? This is according to the 150 to 300 minutes per week in normal adults and 60 minutes per day in children's, and which is a cumulative of more than 300 minutes per week. It is better for it's a good physical activity. Which dietary component has been linked to an increased risk of colorectal cancer, particularly in high amounts, and should be limited in cancer prevention strategies? It is red and processed meat, which is proven to a group certain processed meat, red meats has been classified under group 1, which causes cancers. In terms of body mass index and cancer risk, which of the following cancers has the strongest association with obesity? Out of all the options, endometrial has the highest risk. It is shown that endometrial cancer, when there is severe obesity and body mass index is more than 30, there is a chance of 7 times risk of cancer compared to other malignancies. Which of the following describes the relationship between diabetes mellitus and cancer? It is hyperinsulinemia. These are the mechanisms of how diabetes mellitus causes cancer, mainly hyperinsulinemia, which will activate the kinase pathway, cell proliferation, and cancers, and also inflammations. In the context of obesity and cancer, which of the following is the most likely biological mechanisms linking obesity to an increased risk of certain cancers? It is oxidative stress, and chronic inflammation, which is called meta-inflammation, because this inflammation will cause pro-inflammatory cytokines, which will cause dysfunction of the immune system and development of cancers. Thank you.
We end our session today, and we'll take over the next session on 14th February at 3 p.m. Good evening, everyone. Thanks so much.